Dr. Shafer, thanks for joining us. The story in medicine today is diabetes. It seems to affect so many other aspects of the entire debate about health care and what we're going to do about it and how we're going to afford it as a country. Diabetes keeps looming large. I read 25, what does it say here? 26 million children and adults in the United States have been diagnosed with diabetes.
That's correct.
That's, what is that, 8% of the population?
Yes, it is.
Has the number always been this high?
No, and that's the disturbing aspect of this whole issue. 50 years ago, between 1 and 2% of the population had diabetes. About 2 decades ago, this began to increase exponentially, not just straight line, but
On a curve.
On a curve, and the curve is accelerating, so that we would actually project that by the year 2070, 2080, at current rates of growth, virtually the entire population will have diabetes, which is what's disturbing healthcare planners today. There's no way we can afford to take care of a population where everybody is suffering from the effects of diabetes.
The American Diabetes Association estimates that in addition to that 8.3% of the population that is diagnosed as having diabetes, there could be as much as an additional 7% that's undiagnosed with
That's
diabetes.
correct.
How can you have diabetes and not know it?
Well, in the early stages of diabetes, when the blood sugar is mildly elevated, it's still elevated enough to cause damage, such as heart attacks and strokes, but there are no symptoms. The blood sugar has to be considerably elevated before we see the classic symptoms, such as frequent urination, thirst, and weight loss. Before that stage, it's completely asymptomatic, and there's no way that a person would know that they had diabetes unless they had specific tests.
Yet another alarming statistic. Estimated 79 million people estimated to be or believed to be pre-diabetic. Let's define pre-diabetes.
Well, pre-diabetes is when your blood sugar is above normal but not high enough to qualify for diabetes. And these are simple numbers. If your fasting blood sugar, the blood sugar before breakfast, is over 126 on more than one occasion, that's defined as diabetes. A normal fasting blood sugar is less than 100. So that gap between 100 and 126 is called prediabetes. It used to be called borderline diabetes, but we don't like the term borderline, and the term that we prefer now is prediabetes because it suggests that there's a high probability of the development of diabetes in the future for that individual, for those 70 to 80 million people that have that diagnosis.
You may have answered this. How do you test for prediabetes? It's a blood test.
Simple blood test. If an individual's blood sugar fasting is between 100 and 126, that's in that gray zone, not high enough for diabetes but above normal. That's called prediabetes, and that individual has about a 10% per year chance of going on to develop diabetes. In 10 years, you're looking at close to a 100% chance of developing diabetes.
All right, well then let's follow that question logically. If you have prediabetes and it's 10% per year that you have it, is diabetes inevitable or can you reverse it?
Well, it's not inevitable, and that's the good news. That 10% per year is if an individual does nothing, continues their current lifestyle with inactivity, usually overweight. An individual that develops diabetes is usually 20% overweight. If that person loses as little as 5 or 10 pounds and becomes active, they can reduce their risk of diabetes to the same as the general population, between 6 and 8%. So a lot can be done. There also has been a large study, the diabetes prevention trial, that has shown that in addition to lifestyle change, weight loss and exercise, a drug called metformin also is helpful in preventing diabetes, preventing people from prediabetes from developing diabetes. But 60% of the benefit in that study was from lifestyle change, the sort of things that everybody can do independent of medication.
You just mentioned the statistic 60%, so here's a little segue. 60%, I'm reading here, of all non-traumatic lower limb amputations are attributable to diabetes. If you have diabetes, what is the likelihood that you will lose a lower limb, a foot or a leg or some lower extremity?
Well, a number we can all relate to is that 230 people per year in the United States have diabetes. If you do the math and you look at the number of people with diabetes, that's about 1 out of 250 people per year with diabetes will have an amputation. Over a 40-year career with diabetes, that would be 40 out of 250 to put it in numbers that we can deal with. Now, the good news there is that amputations are not inevitable. In fact, most of them, 90 to 95%, are completely preventable with simple foot care, things that we teach in diabetes classes.
What is it about having diabetes that puts one's lower extremities at risk?
Well, that's a good question. There's actually two things that cause the problem. One is neuropathy or nerve damage, and the best way to illustrate that is that I've had a patient that walked around all day with a roofing nail in their foot, and they did not feel it because their foot was so numb from the effects of having diabetes. That's long-term diabetes. The second part of the equation is poor circulation. If you have a wound in your foot and you have poor circulation, that will delay wound healing, plus the effects of high blood sugar delaying wound healing. But both of those can be modified. If a person does not have sensation, they can do simple things to prevent trauma to their feet, not walking around barefooted, for example. And if they have poor circulation, there are definitely things that can be done to improve circulation.
Diabetes is listed as the leading cause of blindness in adults. How does diabetes affect your eyes?
This is a little bit more complicated, but basically the small blood vessels in the back of the eye after a period of time become very fragile and they can actually hemorrhage. Very minimal trauma such as sneezing or a sudden jar can rupture those blood vessels and a person can wake up with their eye half full of blood. Now this is after having diabetes for a minimum of 10 years where we see these new blood vessels forming. Now the good news here is that yearly eye exams by an ophthalmologist can spot these blood vessels in their early stages when they can be zapped by a laser. So blindness is not inevitable with diabetes. Even if someone has these new blood vessels forming fairly vigorously, regular visits to an ophthalmologist can detect these at a stage where vision loss can be prevented. Almost all the complications of diabetes can be prevented. None of them are inevitable.
Let me make sure I get the stats right here. Nearly 13% of African Americans, nearly 12% of Hispanics have diabetes, but only 7% of the Caucasian population is diabetic. Why the difference based on ethnicity?
It really tracks with obesity. You know, we mentioned the diabetes epidemic going from 2 to 8% of the population. That has followed the rates of obesity or overweight in the population. Certain groups, ethnic groups, have a higher risk of obesity due to genetic factors which are still being defined. It's basically obesity combined with a genetic predisposition to diabetes. If you have one parent with diabetes, you have a 50% chance of developing type 2 diabetes if you're overweight. If you keep your weight reasonably close to normal, that risk is 5 or 6%. So diabetes is in the gene pool in most ethnic groups. If we, through lifestyle choices or whatever is available to us, if as a result of that we become overweight, then that will allow that gene to be expressed. So it really is related to genetics, which lead to excess obesity.
So the nexus is weight and not ethnicity, and the nexus between weight can be to ethnicity. So
right. And the genetics,
there's not a straight line between the two.
It's not a straight line, but genetics do predispose us to weight gain.
Right, right, very well. 1 in 3 children that were born in 2010, last year, will develop diabetes during their lifetimes, according to statistics we have here. How do you begin to reverse? That's 1 in 3. That's amazing. How do you begin to reverse that kind of a shocking trend?
Well, it points out that the most important way to approach it will be to deal with the epidemic of childhood obesity. 20 years ago, we rarely saw adult onset diabetes in individuals under the age of 40 or 30. Now we are seeing adult onset diabetes in kids as young as 10, 11, or 12, and it's related to childhood obesity. All of these kids that develop diabetes at this age are very overweight. So we have to figure out ways to prevent kids from becoming overweight in order to prevent this future onslaught of adults that are going to have diabetes. Once they develop diabetes, it's obviously much more difficult to reverse diabetes and prevent the complications. But if we can somehow prevent kids from becoming overweight, then we will not only prevent diabetes, but all the other sequelae that go with overweight, such as heart disease, increased risk of stroke, increased risk of our joints wearing out before it's time. Even an increased risk of cancer is associated with overweight.
So let me put you on the spot here, and I don't expect that you're going to know down to the last dot the answer to the question. But if we as a society went back to what we weighed in the 50s and 60s, how much pressure do you think it would take off of the healthcare system and the cost attendant there too?
Well, it would no doubt prolong the time before Medicare went bankrupt by another 30, 40, or 50 years. In other words, a very significant factor. I'd be very hesitant to give you a statistic that you could hang your hat
on.
But
I understand that.
But it would be a major benefit to our healthcare system, decrease healthcare costs, but not only that, but just decrease the burden of human suffering, which is hard to put a price tag on, but the fact that people will be able to work longer, enjoy life longer, and be contributing members of society for a longer period of time.
I guess the point would be, as we argue now almost continuously about how we're going to pay for health care, and a lot of it could be paid for just if we weren't as heavy.
If we could figure out that, it's a simple solution, but it's not easy to figure out.
Right. Simple in concept, very, very difficult in execution.
But it's really key, and that's where a lot of our research money and focus should be. We tend to spend more money on fixing problems after they develop, but if we could really make this be a major focus, preventing childhood obesity, then this would reap tremendous dividends in the future and prolonging our ability to be able to take care of ourselves.
Very well. Doctor, it's very interesting. Thanks for your time today.
All right. Thank you.